presenting this topic that has always been very close to my own heart, which is fetal heart examination. And today's webinar is on the use of artificial intelligence, and I like to give you some ideas and some tips for you to use all these new tools that we have now in our hand. And it's very important to diagnose, to perform fetal heart examination if we want to diagnose congenital heart defects, so very frequent overall. And but we have learned over the years that if we want to detect congenital heart defects, we must not only screen high-risk pregnancies, which means pregnancies with a history of heart defect, etc., but we must screen and we must look at the hearts of every single baby. So it must be population screening. And therefore, that implies a lot of resources. We need trained sonographers, trained doctors, and there needs to be a pre-specified program. Most of the screening programs consist of at least the 4 chambers view, hopefully 4 chambers and 3 vessels, and the vast majority of the world has implemented the 5 standard views recommended by ISUOG in their programs. Once an anomaly is suspected, the patient is referred for a fetal cardiologist assessment that will perform a sequential analysis, structure by structure, to give a diagnosis and put a name on the condition. Now, I'm going to focus in the 5 standard views because this is what we actually do on our daily basis. So here you have the 5 planes that we need to acquire, more or less. They are all in axial views, a little bit of tilting in our probe, and we need to go through from the first plane, the situs view, move up to the 4 chambers view, left ventricular outflow tract view, right ventricular outflow tract, or the 3 vessel view, and finally we move up to the 3 vessel trachea or the arch views. And those are certainly the images that we must always get in our screening 20 weeks anomaly. We must get and we must document that we have looked at all these 5 planes to rule out most of the congenital heart defects. And as I said, this is mandatory. This must be recorded and this must be documented. So I've always when all these AI tools started and we were just freezing the image and automatically we were acquiring biometry and so on, I was always saying, but if we stop the image and the software already recognizes what we are seeing and is able to measure, why not to measure live? So the question is, what if we could just take a clip, scan live, and then without stopping, without freezing, without going in a loop, back, forward, just automatically as the software is recognizing the different views and the different planes, it's storing the images as still images, not as a clip, as still images, the ones that we need to record, and even label them. There are some settings that previously I didn't need to, but in my current position, sonographers need to label every single view. So why not to do that since the technology was already there? And that is exactly what we can do nowadays. So we can just focus on scanning. We can, as you can see in the video, we are performing our live scan. We go situs, 4 chambers view, 5 vessel view, 3 vessel and 3 vessel trachea views. And on the left, you can see how we have a checklist. So we are not depending on following always the same scheme that sometimes is not possible because of fetal position. So we have a checklist that automatically is telling us what structures we have seen, what structures we have recognized. And if you see here on the right hand side of the slide, you can see how the images are being acquired and they keep coming on our board, and the basically is corresponding the checklist and the images, and we are acquiring all the necessary views. Here you can see that it is yellow and there is green, and I will comment now on that. But basically, we have done a live scan, and the software, our AI tool, has recognized the structures, has stored the views, and has even labeled them, as you can see here, 3-vessel trachea, 3-vessel view. So certainly that will reduce scan time, because we won't be freezing, we won't be going back, forward, and it will also reduce operator dependency. So it will be getting the best possible image. And I don't know if you realize, but some images were being replaced because when one image has been acquired, but there's another one, a second one that comes that is better, then it is replaced automatically. And at the end of our scan, we just need to scroll down and review all of them, discard the ones we don't want, and accept the ones that we are happy with. So I was saying yellow and green. What is that? Okay, so let's say in addition to what we just mentioned, we can check the image quality. What's that? Here you have. I gave you my previous 4 chambers view that I thought I was very happy with it, and I was giving you as an example of what we should take. And therefore, if we are examining that image with a quality check, like is to assess how good it is, we have, so the software has a series of landmarks that we will need to, that the image will need to meet. You can see left ventricle, right ventricle, left atrium, right atrium, the mitral valve, the tricuspid valve, the apex, the interventricular septum, the atrioventricular, the interatrial septum, the pulmonary veins, and the descending aorta. If all those are clearly visible in the image, that will give us a green light. However, what my surprise was when I saw that I got a yellow for this image, and I didn't realize, but the software did, that actually you cannot see this pulmonary vein in black. Here I couldn't see the second pulmonary vein entering the left atrium. So I must say I was quite satisfied when I saw that was the software was capable of spotting my mistake. Let's put it this way. Here you have an example of left ventricular outflow tract. You can see the left ventricle, the right ventricle, and these are the landmarks. The left atrium, the ascending aorta, the apex, and the interventricular septum, which is intact. And therefore, all the criteria are met, green light. And finally, there are many other views. These are not the only ones, but probably these are the ones that are more helpful to illustrate what this is about. This is the 3-vessel trachea view, and here you can clearly see the pulmonary artery, the ascending aorta, the superior vena cava, and the trachea, and therefore green light. So I hope you belong to one of those places where you routinely monitor images to assess quality of your sonographers, of your team. If that is the case, you will for sure be reducing time, and at the same time, because there will be so many images that will be assessed, you will increase the number of images assessed, and therefore at the end of the day, operators will receive better feedback and the patients will receive overall a better assessment. And of course, whether it's ready nowadays or it will come in the future, or our software in particular does not have it, but everything that we do in B mode, we also need to do, and we also need to acquire and be specific in color when assessing in color Doppler. Now, we've performed our screening, we suspect an anomaly, and we refer the patient for a fetal cardiologist's approach, which is this sequential analysis that I was talking about and I learned back in my time in London. Basically, it consists of looking at everything. So you start from the bottom of the heart to the very top. You assess the position of the heart and the apex, the atrial situs, the atrial morphology, the ventricular and the arterial morphology, the AV connection and the VA connection, and if needed, because that's the suspicion, even cardiac function, and we will have to use B mode, color, and spectral Doppler. So I'm not going to go through all that because that's not the objective of this talk, but to start with, I will say that we may use the previous tool that I was talking about also for the most complex view. First, we can label each single structure of the heart. We will just need to freeze our image, press the labeling button, and everything will come documented. We will be able to measure, and we can select what we want to measure, whether it's atrial width or ventricular width, or perhaps the ventricular area, ventricular length, or we can also select to measure all of them in one go. We can also measure the cardiac axis, and I will clean out all those just to show you the cardiac axis in a better way. So this is only hitting a button. You don't need to place any caliper whatsoever. It comes just with the automatic and artificial intelligence recognition of the image that we have acquired. And as I was saying, that does not only apply to the 5 planes, to the 5 ISUOG views. It will also apply to other sagittal and short axis view. You saw there how the bicaval view was checked here on the left-hand side of the screen and collected also in here. Now you will see how the ductal arch will also come as registered and is in here. And if you freeze the image and you just press your label button, the several parts of our aortic arch will be labeled, the ascending aorta, the branches, and the descending aorta. And if we just say measure, all the specific parts of that structure will be the same, again measured. Again, you can see now ductal arch has been checked as viewed and has been stored in here, and so on and so forth. So again, as I was saying, you don't need to tell it's the ductal arch. It will be automatically stored and labeled as ductal arch. So, and just to conclude with some other tools that are available or will become more and more available when we do cardiac function assessment. We tend to do indexes, the T index, the MPI index, and basically they are easy to obtain, but they are tedious, they are laborious. We need to take here, take there, and then do all the measurements and all the calculations. So basically, I'm going to show you an example. Is the right ventricular MPI. So we just measure the right ventricular inflow here, and we need to make sure that we store that image. We save it. Then we move to superior to get the right ventricular outflow posteriorly to the pulmonary valve. And once we have collected that view, we store it, and we will have to press the specific button with the index we want to measure, in this case right ventricular MPI, and we will just need to scroll and to take the images that is associated to the inflow and the one that is outflow, and the software will just recognize the different times of the cycle and will give us the calculation. So I just want to conclude by saying that this is a very exciting new era that we are entering. Artificial intelligence coming to help us. It will first help us save time, because you've seen how much wasted time we are avoiding. We don't want to do or waste our time in repetitive or tasks that we don't really need skills or specific knowledge, like placing calipers or calculating scores, or so if we save time from there, we can invest that into looking at other structures that we were not looking at for the sake of time before, or we can start measuring, because we don't measure because it's time consuming. So we could start measuring it, that perhaps we will be able to spot subtle changes that will improve our diagnostic increase and improve our diagnostic yield, or I don't know, we will also have more time with our patients, counseling, assessment, And ultimately, we will have more time to do research. That is something that we are always lacking time for. And secondly, and I hope you take this as something good to us, these tools are also here to monitor us and to help us perform better. And to you saw how we can overlook things, and perhaps with a little help, we can get better images and therefore better assessments. So if you ever have an idea, this is a new world coming, please speak up, talk to your provider, talk to all of us. Let's do research and keep improving. Thank you very much for your attention.
Thank you. Thank you for the wonderful presentation.